I'm Nicholas Short from Cancer Center. So the outcomes for patients with ALL are steadily improving over the last several years with the introduction of new monoclonal antibodies such as inotuzumab, ozogamicin, and blinatumomab. These have certainly been proven to improve outcomes in the relapsed refractory setting. And then now we and others around the world really are investigating the use of these drugs in the frontline setting. So inotuzumab ozogamicin is an anti-CD22 antibody-drug conjugate. This has been studied in combination with hyper-CVD in older patients with newly diagnosed Philadelphia chromosome negative B-cell ALL. This is a study that we have done at my institution. And we have shown that with the combination of mini hyper-CVD with inotuzumab, with or without also the addition of blinatumomab, we can get long-term survival rates, 3-4 year survival rates of around 40 to 50%. And so this certainly seems much better than what has been achieved historically with standard chemotherapy in this older population, where historically the long-term survival rates were only 20%. So based on that, we can see the benefit of adding these drugs, including inotuzumab ozogamicin, into the frontline setting for older patients with newly diagnosed ALL. At this year's ASH meeting, there's also two abstracts by different European cooperative groups that are reporting data on the addition of inotuzumab in the frontline setting in combination with low-intensity chemotherapy for older adults with newly diagnosed ALL. These also have shown very encouraging data, providing further data for the use of inotuzumab in this setting. At ASH this year, also, we will be presenting data of our ongoing study of hyper-CVAD with blinatumomab for younger, fit patients with newly diagnosed Philadelphia chromosome negative B-cell ALL. And now we are presenting data with the addition of inotuzumab into that regimen. So the way that that regimen works is it's 4 cycles of intensive chemotherapy with hyper-CVAD, followed by 4 cycles of blinatumomab, and then a maintenance phase of about 1.5 years of POMP alternating with blinatumomab. We initially treated 38 patients with the combination of hyper-CVAD and sequential blinatumomab. And then now we've added 24 patients. We've added inotuzumab into that regimen. So we use low-dose fractionated inotuzumab given for 2 cycles during the intensive chemotherapy portion and in 2 cycles along with blinatumomab. The data so far appears to be very encouraging. So with the hyper-CVAD and blinatumomab without inotuzumab, we have a 3-year survival rate of 81%, and this is still very encouraging and appears better than has been shown in other studies of intensive chemotherapy alone. Now that we've added inotuzumab, the follow-up is still relatively short in that cohort. The median follow-up is only around 1 year, but the estimated 1-year survival is 100%. There have been no deaths in that group. So that is very encouraging, suggesting potentially the addition of inotuzumab is further improving outcomes in that study. We await longer-term follow-up, but we hope to continue to show excellent durable responses with the combination of hyper-CVAD, blinatumomab, and inotuzumab. And I think all of this contributes to the literature, which is also being reported by many others, suggesting that these novel monoclonal antibodies should be sequenced upfront with standard ALL therapy to further improve outcomes for patients with this disease, and also hopefully to reduce the need for transplant for many of these patients.